This pandemic of ours has revealed many unsettling truths about the United States. To cite but three, our public health system is fragile. We lack sufficiently robust and sophisticated communication strategies that can relay fact-based knowledge in a highly fluid and politicized environment. And radical inequalities in the social safety network run along gender, race, and class lines. For those of us who work in areas of inquiry that are based in, say, histories of racial inequality, these comments are not so much revelations as they are facts on the ground. However, the physical and psychological disruptions of the pandemic have made it difficult for large swaths of the population to remain in denial about these truths.
This conversation, this project, Black Bodies, Black Health, Imagining a Just Racial Future, is kind of an idea that Michelle and I had because I'm a sociologist and she's a humanist. And for both of us, we talk about things in related but very different ways. Why does centering the Black body matter? Because if we're going to talk about racial disparities, we could talk about a lot of things, and we can start in a lot of places. For us, centering the Black body is where we begin. Just 4.5% of images in general medicine textbooks show dark skin. And this was done by researchers at the University of Pennsylvania. This base level of representation, or more accurately, the lack thereof, has implications for who and what we see as normative, who's characterized as well and unwell, and which bodies we value and which bodies we don't.
As we talked here, as patients, we as Black people don't go to the doctor, we don't trust our doctors, we don't know what to ask, and we don't know how to assist them in treating us.
We wanted to help and partner with the Robert Wood Johnson Foundation to understand how do we come to a point where white bodies are naturalized and Black bodies are invisible.
This project at large, and Anna and my conversations, was very much, so what would we learn if we actually brought humanists, social scientists, and biomedical researchers together into the same room from your disciplinary perspectives to explore, unpack, and disrupt structural racism in the service of creating equitable health outcomes? And I actually want to flag disrupt there because the idea wasn't just to bring you all together to talk, it was also with an eye towards disruption.
Disruption really means trying to figure out how you can intervene into a clinical process. Both to change perspectives and assumptions of clinicians and also to empower patients and their caregivers.
A couple of the things that were most illuminating were really around, how pervasive anti-Black attitudes have been and anti-Black racism has been, especially when I talk to people in other fields outside of psychology or outside of applied, mental health field. I am trying to develop and pilot a cultural humility toolkit for mental health providers. The biggest thing is being able to really meet that person exactly where they are and really talk to that person, that client that's sitting in front of you about, what has your experience been like and how does that kind of translate to what's bringing you in today for help and support.
I think we can be disruptive methodologically in working against the grain of how we practice our craft within our disciplines, how we actually undo, unlearn, and reimagine these processes that are contributing to these unjust outcomes. My focus is on the case of mass incarceration and the carceral state, and the way that mass incarceration and carceral state sort of inherits and compounds endemic health inequalities.
My experience has been amazing with the Black Bodies, Black Health Project. And one of the things that has been so inspiring, but also surprising, is the degree to which I'm experiencing this entire project and the administrators and supporting staff almost as a space of academic healing.
So the way I'm defining disruption is to rethink environmental racism in more complex ways. If you look at Black communities, those communities disproportionately, regardless of income level, education level, all those communities are disproportionately cited for toxic chemical disposal. They were disproportionately impacted by the emissions, both in the air and in the water. cancer rates started to go up, that miscarriages went up, that particularly breast cancer rates went up.
Some of the discourses around poverty and like so-called urban blight, that they can really be made to seem as if it's the community's fault, that they're bearing these inequitable burdens and health impacts of environmental contamination. I'm thinking here specifically of environmental justice communities. One of the takeaways has really been to think about how to push back against some of those individuating aspects from the broader medical or public health establishment. Communities can come to understand that what they're experiencing are not personal shortcomings, but really are the markers of oppression that they're facing. And that recognition, I think, can be really important for thinking about further action.
It really is a great opportunity to understand the impact that we're having across the university and really the perception within an interdisciplinary approach. I mean, this is something in the practice of psychology that we focus a lot on, understanding that historically we would operate on an island, and that's not an effective way anymore. We need to work with our colleagues across multiple disciplines.
Just looking at the experiences of Black student athletes at predominantly white institutions and historically Black colleges and universities, I think both in terms of just their experiences were similar in that they're experiencing race-related stressors both in the classroom, on the court, just in the general community. And so I think just speaking to the importance of interdisciplinary work and research, I think we need people from history, anthropology, sociology, medical professionals, mental health professionals, all of these different groups coming together. So trying to take the research and all the data we're gathering and then generating some way to intervene and promote the health and wellness of Black bodies and Black student athletes in particular.
It's really exciting to be able to give some evidence-based physiological markers to people's lived experiences. That's not something that we're able to do a lot in social science.
My experience in the BBH project has been fantastic. We looked at the clustering of Black workers in frontline occupations during the pandemic. As we moved through the project, we started to step back and again look at context. How have these disparities in health and in wages and employment been allowed to linger, persist, and get bigger over time? We really benefited from the BBBH project because of the interdisciplinary point of view and learning to take in context in our study.
This started us thinking about how can we provide a resource for individuals to find physicians of color. And the information we obtain is one we will publish and use to launch our app.
Technology uniting like-minded physicians and patients, and that's the app. So the app is basically designed to build up a directory of like-minded physicians that residents in New Jersey can go to and search out in their area, neighborhood, or wherever they're looking for.
Disruption requires, to some degree, a level of discomfort and not knowing what's going to happen when the status quo changes. So that type of innovation is what's necessary to really produce something completely innovative and not something that's just a reshaped or refashioned version of existing systems.
First, we need access for all. We also need compassionate care. Just giving a pill is not enough.